Well, good afternoon to all of you. Thanking NIC as well as Viva for the opportunity given. Well, over the next 10 minutes, I shall share with you few of our interesting cases which was helpful in decision making during our interventions. Well, the first case, um, uh, regarding the usefulness of IVUS NIRS in routine practice, it helps to identify the procedure risk involved during an intervention. Well, this is the first case, 83-year-old gentleman who presented with an acute coronary syndrome, a proximal LED, very critical stenosis. We did a NIRS evaluation, IVUS NIRS evaluation of this particular lesion, and we made out that in this particular lesion, you can see when you look at the IVUS, it's more of an attenuated plaque over here, and when you look at the LCBI, you could see that it's 722. An LCBI max of more than 500 correlates with a slow flow during the procedure. So when you have a huge amount of lipids inside the lesion, you shouldn't be very aggressive at that particular lesion. You shouldn't be post-dilating it with very high pressure balloons. So that makes us understand that you are encountering a difficult lesion. You're likely to have problems during the intervention. So that sort of information was what we achieved in this particular lesion. We dilated it softly and deployed a stent over there. Despite directing and deploying the stent very at low pressures at 12 to 14 atmospheres, you could see in the second image that we encountered a slow flow in that particular vessel. LED and diagonal also we encountered slow flow, and following intracoronary vasodilators we were able to achieve reasonable flow in LED. However, the flow in the diagonal was not all that great, probably because of distal embolization. Well, this was another situation. One could identify high-risk vein graft interventions. We know that all the vein graft interventions are going to be high risk. However, you could classify whether this particular patient is going to have a distal slow flow during the intervention. This is a patient who had a critical stenosis. In the distal vein graft, you could see that in the frozen image, there is a critical discrete lesion in the vein graft. When we evaluated this, we made out that it was a soft plaque. We also made out that there was no significant lipids. You could see in the chemogram that the lipid score was around 101, no significant lipids, which makes us understand that it's not a very high risk lesion. It's unlikely to embolize distally and produce low flow. So we went ahead with direct stenting. We did not use a distal protection device. Direct stenting was done and we could achieve good flow inside that vessel. And then following the next pullback made us understand that there was no significant lipid over there, and that was the final result. This is another patient who had a vein graft to the dominant circumflex. You could see that it's totally occluded with a very critical stenosis in the proximal segment. It was a stented segment. Almost 10 years ago, it was probably more of a new atherogenesis. When we did an IVUS evaluation and NIRS evaluation, we made out that there was a huge amount of lipid at that particular area inside the restenotic segment, which was more of restenosis and more of a new atherogenesis over there. We made out that the LCBI max was around 611. So we were sure that we need to protect this vein graft to avoid distal embolization. So we had a distal protection device. We used a laser, we used a cutting balloon, we used a drug-eluting balloon, and then finally we were able to achieve good flow in that particular vessel. So NIRS made us understand that one was a high-risk lesion and the other was a low-risk lesion. So in the high-risk lesion, we used laser as well as distal protection device for managing this particular patient. Now we could also identify low-risk subset of patients with the help of NIRS IVUS. This is a patient who had an inferior myocardial infarction, underwent stenting to the right coronary artery. You could also see that there is a plaque rupture in the left main bifurcation. So we wanted to evaluate that particular area, the left main bifurcation, almost 40 to 50% lesion over there. So we went ahead with NIRS evaluation. You could see in the IVUS image that it's an ulcerated flap over there. It's an ulcerated flap, and you could also see in the second frame that the minimal luminal area is almost 10 millimeters square. So even though you had an ulcerated flap, the minimal luminal area was 10 millimeters square, and we also evaluated the amount of lipid pool over there. It was less than 400. So when you have a lipid pool of less than 400, LCBA max of less than 400, this correlates with less of future events. So we understood that the lumen was good. There was no huge amount of lipid pool. So we decided on intense medical management rather than going ahead with a stent implantation at the left main bifurcation. Again, you could identify the landing zones. Dr. Mahesh has explained in detail regarding that. This was a patient who presented with an acute coronary syndrome. You could see a tight lesion at the LED D1 bifurcation. Distal lesion is a tight lesion. In the proximal vessel, in the proximal LED, you tend to see a hazy looking lesion in the proximal left antidescending artery. So you have a tight lesion distally, and you also have a proximal hazy looking lesion which doesn't appear to be a significant lesion. So is it important? So we evaluated with IVUS and NIRS. In the first image, you could see that the plaque burden there is almost 70%. It's a huge plaque burden. The second image, you could see that it's an attenuated plaque in IVUS, And in the third image, you could see that in the proximal LAD, the LCBA was 642. It was huge amount of lipid there. So we understood that proximally there was huge amount of lipid with a huge plaque burden and an attenuated plaque. Distally also we made out that there was a significant amount of lipid pool. It was again 536. So we decided that we shouldn't be just stenting the distal lesion alone. We should be extending the length of the stent. So we covered the both the lesions. We deployed a couple of stents and got a good result, and that was the LCBA following the stent implantation. And then there are situations wherein when you do a bifurcation, you could understand which vessel has got a lot of lipids, and you could avoid multiple stents in those particular situations. Let's say this was a patient who presented with an infused myocardial infarction, occluded right coronary artery. We opened both the vessels, and then we understood that it was a diffusely diseased RCA. The PLV was diseased, the PDA was diseased, and even the proximal right coronary artery was significantly diseased. So we wanted to avoid multiple stents implanted during the acute myocardial infarction. So we did an IVUS NIRS evaluation. You could see in the first image that in the distalmost portion, in the PLV, there was huge amount of lipids, and in the proximal right coronary artery also the intermediate lesion was having huge amount of lipids. We also had a pullback from the PDA branch. In this particular image, you could see that there is no significant lipids in the PDA branch. So we understood that PLV was containing huge amount of lipids. The proximal right coronary artery was having huge amount of lipids. So we decided that we would go ahead with a single stent. We would go ahead with a single stent strategy at the distal bifurcation, and did not stent we used a drug-eluting balloon to the PDA and settled with that. So at the bifurcation, we just stented with one stent, and that was the final result. Patient is doing well after 3 weeks at this point of time. Now, you could also identify during acute myocardial infarction interventions, you could identify the risk of patients who is likely to develop slow flow, and you could categorize them. That is, one patient might be having huge lipid pool, he is likely to have slow flow during post-dilatation. The other one might be having less of lipid pool, less likely to have slow flow during intervention. So you could risk stratify intervention in acute myocardial infarction. This was a patient who had a infused myocardial infarction. You could see in the LCBA, the score is quite high, it's 861. You know that this patient is likely to have slow flow. We did a direct stenting over there. Despite doing a direct stenting, you could see in the second image that there was significant distal embolization, slow flow in this particular patient, settled down with intracoronary vasodilators. And in the second image, this was another patient who presented with an infused myocardial infarction. You could see that the lipid pool was significantly less. It's 168. We went ahead with stent implantation. We went ahead with post-dilatation. Despite that, we didn't have slow flow during the intervention. So just to make us understand that when you have a huge lipid pool in acute myocardial infarction, you are likely to have more of slow flow, and the procedure is going to be more difficult. Now, it could also identify, with the help of NIRS, you could also identify the results achieved during PCA. You can evaluate the results achieved during PCA, which can lead on to MACE during the long term. This is a patient who had a PDA tight stenosis. We went ahead with stent implantation of PDA. However, following the stent implantation, we missed the ostium. 2-3 millimeters of the ostium was missed. So we were debating whether we should be putting another stent at the ostium of the PDA or not. So we did a NIRS evaluation. We made out that at that particular area, at the ostium of the PDA, the lipid pool was 529, the LCBA was 529, so that we decided that we'll go ahead with a second short stent implantation at the ostium so that the future MACE could be significantly reduced. So a second stent was deployed, and then we could achieve good results. Now, one could also identify the unexpected thing during interventions. This is a patient who had an infused myocardial infarction, thrombolized. A stent was placed that was a lesion in the circumflex artery, and we did a NIRS evaluation. There was no significant amount of lipids there at that particular area. However, following stent implantation, you could see that at the end, in the IVUS image, you could see that beyond the stented segment, there appears to be something yellow over there. When we evaluated that, just beyond the stented segment, there was lipid pool which was not initially present, probably because of the redistribution of the lipids pushed by the balloon and the stent distally. And that's my last case. It also helps us to identify the balloon-based strategy in calcified lesion. When you have a calcified lesion, if you see huge amount of lipids beyond the calcium, then probably you need to think in terms of a softer balloon, a non-compliant balloon rather than a high-pressure balloon, so that the distal embolization also could be significantly reduced. This is a patient who had an effort angina, a tight calcific LAD disease, went ahead with rotablation. It was difficult rotablation, and then the flow was good in LAD, and you could see in the second image that it's a sturdy catheter, just to show you that the catheter moves even in calcified lesions very, very easily. And when we evaluated this particular lesion, you could see in the first image that it's a 360-degree arc of calcification. In the second image, you could see in the chemogram that there is huge amount of lipids over there. That's 746. That's beyond the calcium. Beyond the calcium, there is significant amount of lipids, which makes us understand that you can easily open up the lesion. Secondly, if you're very aggressive, you're likely to encounter slow flow. So we just went ahead with a non-compliant balloon and we opened it up. And then following the non-compliant balloon, repeat evaluation revealed that there was multiple breaks in the calcification. The amount of lipids have significantly reduced, and finally we went ahead with stent implantation, and that was the final result. So dear friends, what I was trying to tell over the last 10 minutes was just to highlight the usefulness of NIRS in identifying a high-risk patient as well as a high-risk plague, so that we can modify our decisions during intervention so that we could have a better acute outcome as well as a long-term good outcome. Thank you so much.